All right. Okay, so we're all good. Well, welcome everybody to another session. I call this the AIOBIO QBLISS clinical series of education. I'm very excited about today's information. We've got Dr. Professor Kim here, and what we're going to do is we're going to talk about the importance of biofilm and why I think this is so important. We were talking about this before we started. Is in dentistry and in hygiene, we know about biofilm, but the concepts of biofilm have really changed over the years. We've learned that the biofilm is much more sophisticated than we thought earlier, at least decades ago when I was in school. So I'm going to have Dr. Kim talk about the biofilm and then what QBLISS is really showing us, because some of the questions I often get is, well, it's red, but is the red the good biofilm or the bad biofilm? So we'll talk about that and what the indications really are. And then we can talk a little bit about how we're starting to treat this biofilm and disrupt those colonies. So with that, just want to say welcome. Good to have everybody here. And I'm going to turn it over to Dr. Kim. So Dr. Kim, welcome. And thank you very much for being here and for presenting.
Thank you very much for the introduction, Mike. Okay, today I would like to talk about some caries risk assessment using biofluorescence. A couple of weeks ago, I gave this lecture to some Canberra group. So today I focused on this issue with the Canberra. Maybe you already know the repeated restoration cycle. Repeated restoration cycle is a commonly discussed treatment paradigm in dentistry. Once the restoration is placed in the mouth, this cycle eventually progresses, differing only in the speed. My specialty is preventive dentistry. So therefore, I always aim to block this cycle before the first restoration forms in mouth. In that regard, the Canberra is also important topic to block this kind of repeated restoration cycle. Yeah, I briefly introduced the history of the Canberra. John Featherstone in the UCSF, he firstly proposed this concept. Canberra stands for Caries Assessment Management by Several Technology. They make some specialized group in 2003. Then they published the first guideline. Then next is 2007. They also published the second guideline was presented. Now it's 2021 they improved more and more. Now it's many U.S. dental colleges educated Canberra to some undergraduate course. It means that this is an important protocol to prevent the caries. Yeah, I already also introduced the Canberra 2014 in to the Korea. I published this Korean research paper to the Korean Dental Journal. Okay, many people said the progression of oral disease is very similar to the iceberg. So iceberg, only 10% we can see by naked eye. 90%, most of them is located under the sea level. So we only see above the sea level. This structure is very similar to the oral disease progression. So, for example, the most upper part is the cavity. Many dentists easily recognize the cavity lesion. However, underneath of this sea level, we can find out the white spot, the incipient caries, initial caries level. So we can call it as a white spot. So what is the most deeper part this iceberg? Maybe it's the biofilm, especially pathological dental biofilm located as the most deeper part of this iceberg. So if we detected some pathological dental biofilm by some technology, so we can predict the whole progression of the oral disease. So how can we detect this pathological dental biofilm? So QLF is one of the promising technology. So 2004, firstly developed this technology for the research purpose, but nowadays is the kind of third generation of the QLF. We can call it as the QA cam. This product lineup is actively used in the clinical situation. So today I focused on this topic. Okay, you have to keep in mind that the principle and the clinical use of the QA, we have the two different kind of principle. One is that this technology can detect the tooth fluorescence. Tooth already have their own fluorescence, so if we irradiate the blue wavelengths of light, so we can detect some change in the fluorescent loss from the tooth structure. The most important principle is the second, is the bacterial fluorescence. We can detect the strong red fluorescence from the not only biofilm, but also carious lesion and the dental calculus. This is a very important clinical meaning. Yes, this is the structure and the process of the accumulation of the bacteria in our mouth. Firstly, is the tooth surface acquired particle from saliva. Then is the streptococci is the initially attached acquired particle. So we can call it as the early colonizer. I think the early colonizer is the good biofilm. Academic words is a symbiotic biofilm. Then the Fusobacterium nucleatum is a very important species. They connected between the early colonizer and the late colonizer together. Late colonizer is we can call it as the bad biofilm. So in other words, the dysbiotic biofilm. So usually it's the dysbiotic biofilm. They produce the specialized bacterial metabolites such as the porphyrin. So this is a typical porphyrin structure. There are 4 pyrroline exist. So our hemoglobin is also a porphyrin structure. In the inside the center part, iron is located. We can call it as hemoglobin. Also in plant, in the center part, magnesium located. We can call it as a chlorophyll. Interestingly, bacteria also produce the similar porphyrin structure, such as the protoporphyrin 9. Center part is empty. So this is a very interesting porphyrin structure. If we irradiate 4-5 blue wavelength light to our mouse, we can detect the bacterial porphyrin. Then we can see some strong red color from the biofilm. My department have the several in vitro study. So we want to know how many days we need to detect the red fluorescence from the biofilm. According to our experiment, after the 3 days, suddenly the red fluorescence appeared from the biofilm. So it means that after 3 days, this biopsy is just starting, and the concentration of the protoporphyrin 9 is increased. Then we can detect the red fluorescence. This is a very interesting phenomenon. We also have the experiment more. So you can see some incubation day from first day, second day, 10 days. Red intensity gradually increase. Also, we analyzed some demineralization level of the enamel. Lesion depth is also increased. So if we detected a strong red fluorescence from biofilm, you can predict underneath of enamel, the demineralization is just starting, and the severity also increase. Also, next is that I want to introduce the second part of the white spot. Yes, orthodontic patient is prone to some demineralization around the bracket. So you can see some white spot located around the bracket. But we didn't know about the real lesion depths. How can you calculate the lesion depths? According to our previous research, we collected some hundred of human extracted molar with some white spot. We take the image by Curie. We calculated the delta F. Delta F is the indicated fluorescent loss from tooth. Then we also cross-section the tooth. We calculated the real lesion depths. We make this a kind of a structure. You can see that some correlation level is over 0.94. It means you don't need to cut the tooth. Just take the image by Curie and calculate the delta F. Then we can predict the real lesion depths in the white spot. Yes, these patients almost finally finished the orthodontic treatment. They removed some whole bracket and cleaned the whole tooth, the oroflexis. Then we take the image by Curie. You can see that some strong red color exists in along the gingival line. This is not white. This is not biofilm. This is the active white spot. So we can analyze some real lesion depths of this white spot by delta F value using this software. Okay, I want to show you some clinical example. This patient visited the dental clinic 2012 in the November. You can see that some strong red color exists in the gingival margin. This is an active white spot. We apply the fluoride during 2 months actively. Then baseline is we calculated the delta F value is like this. We apply the fluoride during 2 months. After 2 months later, you can see the delta F value dramatically decrease like this. So now we can say that some real lesion depths using this delta F value, and also we can say the fluoride efficacy by this numerical value. This is very meaningful information in clinical situation. Okay, so I also introduced how can apply some Curie technology to the captive lesion. This is the tooth sample. You can see that some proximal carious lesion exists. We take the image by Curie. You can see the strong red color exists. We cross-cut this tooth. You can see the red color infiltrated not only enamel structure, but also dentin lesion. So this kind of evidence, we can predict the real carious lesion using Curie. So in white light conditions, sometimes it's very difficult to detect the proximal carious lesion. But it's the Curie. You can see the strong red color exists in the proximal area. Yes, you can see the more strong color inside. Then we remove it, and finally we restore the resin, composite resin like this. Our lab and department published many papers related evidence of the Curie to detect some carious lesion. This is the clinical study, not in vitro study. We focused on the permanent tooth in clinical study. We want to use the Curie to detect the proximal carious lesion. So we developed the QS proximal index. We compare with this index to the radiograph and the visual inspection. According to our research, sensitivity and specificity is over 0.8. Is a very high level. So this is our first clinical study result. Second study, we also focused on the occlusal carious detection by Curie. We also developed the QS occlusal index. We compare with this index with the ICDAS. Then also sensitivity specificity is over 0.9. And these two studies, the clinical study to focus on the permanent tooth. Also, we applied this technology to the deciduous teeth, pediatric dentistry. So we detected the occlusal caries and the proximal caries in deciduous teeth. Also, we have the very high validity to detect the caries lesion. Recently, we published the systematic review and meta-analysis using Curie technology. We collected totally 481 published papers. Among them, we finally selected the 17 published papers. Then we analyzed intensively. Finally, we pulled the data by meta-analysis. According to this research, is the occlusal and proximal caries detection level is the over 0. Around 8, so it's a very high level. So I think this kind of evidence is enough to the Curie can detect the caries lesion. Okay, now is the move to the Canberra. Canberra is a kind of a balanced concept. If the disbalance is the disrupt, as the caries is the progress. Most important as the Canberra is the disease indicator and biological risk factor. This is indicator consists of the cavitated lesion in the dentin, white spot lesion in smooth surface. There's a non-cavitated lesion in enamel, restoration past the 3 years, white spot. Also, biological risk factor, among them, I think the acid production bacterial level is also important. If we use the QBLISS and the QRACE system, we can detect this important factor from camera very easily, very easily. So this is a very strong power to apply the camera. Okay, it's the QRACE is the kind of some concept of hardware, but we also need a software, especially AI-driven software. We combine together is the hardware QRACE plus as the AI-driven software. We can call it as the QBLISS. QBLISS stands for like this. So now it's the many Korean data clinic and some of the US data clinic like Mike is actively used the QBLISS system in their clinic. I think about the we can combine together as a camera concept to the QBLISS together. One of the synergistic point is the QBLISS system easily can detect the flag accumulation evaluation. So this system is AI driven, so it's the very you don't need to manual detection. Just take the image and automatically analyze. They show us some this kind of graph. So maybe it's a green color means there's no biofilm. It's the very clean enamel surface. And the red color indicates the biofilm covered area. So if this area is the bigger, it means that they belong to the high risk. So second synergistic point that we can longitudinal tracking of the patient oral hygiene status. So before is there are lots of biofilm, we can see there's some broad area of red color. So if this patient is to maintain the oral hygiene, then as the reduce the coverage of the biofilm, you can see the red color is the narrowing or disappear. So many patients is the recognize the their oral hygiene condition using this graph. This is one of the important part. As I mentioned before, that this kind of equivalent system is the run by AI driven. And so this is a very efficient and the time is reducing. Yes, advantage of the utilize the QBLISS in the camera. So we can precisely detect the flag as a red fluorescence. This is very important. Also, we can minimize the diagnostic variability between the examiner. Also, is that we can easily and objectively identify the key disease indicator using this image and the QBLISS system. Also, we can continuously and objectively monitoring the patient mouse condition using this system. Then we can also connect this data to the teledentistry. This is a very promising part in the future. Okay, as I always think about the prevention, I always apply the connect the prevention to the real dental world. But I always realize that there is some prevention bottleneck exists. Why? Because the subjective interpretation and invisible threat and explanation fatigue, this kind of the strong bottleneck in prevention in real world. However, if we apply the QBLISS system, we can suggest a very strong solution to this kind of prevention bottleneck. So I really stress this point. Thank you for your attention.
Yeah, thank you very much. That's very good. Thank you. So yeah, I wanted to go back, and one of the things that we wanted to remind everybody is if you have any questions, put the questions in the chat. We'd love to answer those for you. Dr. Kim did a great job. We've got about 10 more minutes so we can do Q&A and also kind of discuss some of these concepts. So Dr. Kim, one of the things I wanted to ask is if a clinician has the QBLISS system and we want to evaluate the biofilm, or like we've talked about in past programs, cracks and things like that, what's the protocol? We have to clean the tooth to a certain extent before we look at the red, or is there a certain protocol that you recommend?
Yes, I think there's many clinicians is really focused on the disease, like the caries and like the crack, because our traditional paradigm is to belong to the surgery. So this is a very a common way. However, such kind of diseases origin is the biofilm. So we have to keep in mind the more in the biofilm pathogenesis level. So now, as I mentioned before, we can divide it in the concept as the good biofilm and the bad biofilm. This is the other words, the symbiotic biofilm and the dysbiotic biofilm. So we can easily show the some red fluorescent image to the patients, and we can motivate the patient to the more clean their mouth, and we can induce the more active dental treatment. So this is the very strong motivation tool in dental clinic. So so I usually explain this kind of concept, but long time ago it's very difficult because I always think about how can we connect some real clinical dentistry. This is all very long question to me, but in Korea, is the dental crack is the one of the key, because the dental crack is very difficult to detect it by naked eye. It's a kind of some gray zone, but if they use the curate, they can visualize crack and they can easily explain the existence of crack. So after that, the many dentists believed this technology. Then now is the many dental clinic is the Korea is the have some suffer from the finance by is the implant cost is the decrease, number of the implant is the decrease. So they have to manage the loss of the periimplantitis patient. So this disease also originated from the biofilm. So they have to manage this current situation. So that's why it's now many Korean dentists they realize they have more pay attention to this technology.
Yeah, no, you're absolutely right. And then can I clarify that, we talk about the symbiotic and the dyssymbiotic type biofilm. So the good biofilm does not, as you're showing with your little petri dishes, will not really show up as red, but the bad biofilm will show up. When we start to see that red, then we're getting into the dysbiotic biofilm.
Okay, this technology not detected the bad bacteria. This is not concept. This technology can detect the intermediate bacteria metabolites such as the protoporphyrin 9. This is very important. Not detect the individual bacteria, only detected some unbalanced situation. If the protoporphyrin 9 increase means that there are anaerobic condition, as the most of bacteria want to more iron. This kind of situation is highly correlated with sometimes demineralization, sometimes inflammation. So we can predict the strong red fluorescence indicated that now is the not well balanced situation. Now is the balance is disrupted. We can call it as the dysbiotic. So it means that this is now is more close to the disease level. So there are very complex process. What is the red color? Is the today is the I only focused on the clinician. I don't explain the detail about that, but we already have lots of evidence about that.
Okay, yeah, that's good. So I think going back to the QBLISS equipment and the philosophy, I think one of the things I really like about this is that those of you that are watching this program and are trying to learn more, I think we're truly trying to do the best for our patients. And I think this type of equipment allows us to practice dentistry, I think, in a very patient-centric way. And we've talked about this in other programs where, dentistry, we always wait for disease. And when we see the cavity or we see the gum disease, now we feel like we've got something we can do. And, the insurance companies in the United States, they kind of propagate that, because if I'm going to get reimbursed for a dental procedure, I have to have my bite wing x-ray and I have to show the insurance company that there was interproximal decay, or if I'm going to be paid for a periodontal procedure, I have to have recorded deep pockets and inflammation. And so, you know, in dentistry in the past, we've just waited for problems to evolve and get worse so that we could treat it. And I think, as Dr. Kim, as you were pointing out, that this really allows us to have that prevention model where before the patient gets a cavity or before the patient gets severe periodontal disease, or as you just mentioned, before they get periimplantitis or perimucositis, we can show the patients that they've got biofilm building up in those areas. And those areas, we would like to, we had two choices. We can either wait till disease develops, or for those patients that are concerned about their health, we can treat them minimally invasively and try to prevent any kind of disease. And so the topic that we're talking about today in disease control and dentistry is very much focused around controlling the biofilm. You know, all biofilm, as you mentioned, isn't bad. We do have some good biofilm, and that good biofilm supports our oral environment. But then if we don't remove or keep our oral environment clean, then the bad biofilm begins to build up, and that's when we get that red glow. And so just to kind of, and it's something that, you know, we mentioned, if you have questions about this, put in the chat. But what I find so interesting is the choices that we have is we detect biofilm, and what we can begin to do is we can begin to modify that biofilm. And when we modify the biofilm, we do this in a very minimally invasive way. So we tell the patients, okay, and so I'm trying to stress, I think we can make preventive dentistry actually profitable for the practices. You know, Mrs. Smith, the patient, you've got this area where the gums have all this red. So that red is bacteria, and this is the bad bacteria that's going to attack your gums and your bones. Or Mr. Jones, you've got all this red in between the teeth, and that red is the bad bacteria that's going to cause cavities. So in our practice, what we try to do is, instead of just watching it or asking them, hey, can you brush or floss more, which at least in the United States is very hard to motivate patients to do that. You know, we're using these PeriProtect trays. There's trays that are custom fit to the patient's mouths that are like gaskets around the gum line and in between the teeth. And we use either remineralization gel or hydrogen peroxide at very low concentration. And the hydrogen peroxide will disrupt the biofilm kind of layer by layer. And then if we have any areas like the white spot lesions, we try to remineralize those areas. So I just want to point out that, you know, we have people that watch this from all areas of the globe. And I think we have the opportunity, using this QBLISS system, to create a community that can really focus on preventive dentistry. And I think, you know, originally that's kind of what Canberra was about, trying to really detect caries, classify it, and then come up with a conservative way of treatment. And I think that's one of the exciting things. And we were talking about this a couple days ago during another webinar where we have a couple things I want to stress to the clinicians is when you saw what Dr. Kim was talking about, he's talking about the depth of lesions. He's talking about bad biofilm and good biofilm. The MCA analysis, which shows us, you know, how much of good there is and how much bad there is. And there's so much information that we can garner from the system. And Dr. Yoon has shown us before in previous programs how you can even use this to do aesthetic simulation. So this software that backs the QBLISS system is so important. And there's a couple things. I want all the clinicians watching this to understand two things. One, this workflow is very easy to implement. If you're in your office, and especially if you have an aesthetic office, many of us are taking a lot of photos of the patient's face, and oftentimes their retracted smile. With the QBLISS cam or the Q cam, we can get in there, we can take that same picture. And again, the way it works is you focus the camera, you hit the button to take the image capture, and the camera itself is doing both the white light and the red light image consecutively, not simultaneously, but consecutively. And then when we go intraorally and we're looking for the biofilm, we're looking for the cracks, we use an intraoral camera, which it's called the pen, but it's basically just an intraoral camera, which again, many of us use. I think over 60% of the practices use that in the United States. So this equipment isn't equipment that you would not be familiar with. This equipment is not equipment that will disrupt your workflow at all. Actually, it fits into your workflow. And then as Dr. Kim was showing, the little where it all kind of gets constricted in our workflow is that now I've got all this information, or maybe I just have a patient with a lot of biofilm that I can see, but now I've got to explain it to the patient. Well, if I've got these images that are the white light and the red light images, and I tell the patient, look up at the screen, see that red is bad. That's where disease is going to develop. And we've got these minimally invasive treatments to help prevent that from turning into bad disease by disrupting this biofilm. Is that something that interests you? And so, again, the practices that use this find that they save time. They don't have to explain everything, as Dr. Kim was talking about. It's very frustrating sometimes. And actually, revenue goes up because now the patients understand what's going on and they say yes to the treatment. And I think that's the important thing. So, Dr. Kim, I really thank you for the information you provided. And, you went into depth about everything that we're able to see with this QBLISS system. And I just want people to understand that it really is that easy. It's not hard to implement. It fits in your workflow. And again, we're developing this community, and I hope more and more of you will join our group. I hope you will spread the word, because we'd love to have thousands of people that join these webinars. As we learn more, you'll learn more. And I think that's going to make it easy to disseminate this information throughout the globe. And I'm very excited about that, because, whenever anything's new, we always kind of shy away from it. But this is a piece of technology that will really differentiate your practice. And, those of us that are practicing, we always trying to figure out, how do we make our practice appear better to our patients? And, this is one of those really simple things that I think, and I always tell people, why did I implement this into my practice? Because if I have my children come to my practice, or I have my family come to my practice, I want to offer them the very best. The very best is being able to detect things that may be like the tip of the iceberg that we can't see. And with this QBLISS system, we can do that. And then I can provide the treatment that's as minimally invasive, so that we can keep those teeth off of that circular tract that Dr. Kim, you were showing us, where we start out with a small filling when you're young, and by the time you get to be 60 years old, that tooth has to be lost. So everything you said tonight just really it was right on point and very important. So I really thank you for taking your time out to present to us.
Yeah, thank you, Mike. Yeah.
Yeah, thank you. Thank you, Dr. Yoon, for being here.
Now let me explain the one thing. So to understand what is the future of the QBLISS technology, is after understanding the history about our technology, then actually you can think about what is future. And originally, actually, the Dr. Kim, the research is just carriers, right? And then actually we found the crack, and then the biofilm. So now actually we focus on the biofilm. So yesterday, actually, the scientist visited my clinic to learn how to take the Q-ray pen image. But actually, they were surprised why, the number of the image from the Q-ray Cam Pro is more than, the image from the Q-ray pen. So actually, 10 years ago, when we started the QBLISS technology, we focused on the Q-ray pen image, just the disease, crack and caries, right? But actually now, actually, we realize the importance of the biofilm. So the number of the image of the QBLISS, as a Q-ray Cam Pro is absolutely more than Q-ray pen. That is the reason, because of the biofilm. So biofilm is important. And then finally, why we invented the simulation, aesthetic simulation program. I thought the final goal of the dental treatment is that function and aesthetic, right? To make best function, and then we should make the aesthetic align the anterior, the teeth, right? So function and aesthetic is not separate, combined. Yeah, so that is the reason why QBLISS, the software provided, biofilm detection, caries detection, crack line detection, and patients want to know what is the result of that kind of treatment. That is the reason why QBLISS include the evaluation, disease diagnosis, and aesthetic, the simulation. Thank you, Mike. Yeah, thank you, everyone. Yeah.
Yeah, no, thank you very much for the background and for the vision. That's very good. Thank you. Well, I know we've hit our half hour. Again, if anybody has any questions or chat, feel free to bring them up. We're not in any rush to go, but I know other people have scheduled their time accordingly. But I just want to say thank you. I don't see any chat questions on my side, but yeah, I just really want to thank everybody. We'll see you in a month. And Dr. Kim, thank you very much. I always enjoy learning from you. Your insights just always bring such value to what we're doing with the system. Dr. Yoon, thank you very much for you and your team for the inspiration and the continual improvement. And that's one of the reasons why I like to have these meetings once a month, so I can keep up with everything you guys are doing.
Yeah.
So,
Bye.
yeah. All right. Well, everybody, thank you very much. And we'll see
Good
you
night.
next month.
Michael, good night.
Good night.